nucleoplasty, discectomy. We are starting with annuloplasty, but if there is any disc material herniated, you can easily remove, same like for the conventional transforaminal discectomy. Here you can see only annuloplasty. We are not doing any intradiscal procedure. This is the annulo and nucleoplasty. So we perform first denervation, then we are going inside the disc and performing nucleoplasty, intradiscal decompression. Here we can perform discectomy and annuloplasty. So annuloplasty, but also if there is any free fragment, we can easily remove, same like for the transforaminal endoscopy. This is the patient with chronic recurrent low back pain, more than 2 years. Before had eye depth, and the vascular was 8. We perform only tele at the level 4.5. 4 weeks after, the vascular dropped down from 8 to 1.5. Another one we did tele and annulotomy L4-5 on the left side, and again it was only annuloplasty and annulotomy for this patient on the left side. This is interesting case because this patient had nucleoplasty, epidural injection, physical therapy, traction. We perform only annuloplasty, and 6 months after, the vascular was more than 50% less. We didn't make any intradiscal procedure. He nicely improved his discogenic back pain. This is the patient where tele and nucleoplasty were performed at the level 4.5 on the left side. Another one you can see downward migrated L1-2 and L2-3. It was cranially migrated, so we did annuloplasty and discectomy like for conventional transforaminal approach. So you can perform everything. This is the images intraoperatively for this case. So first annuloplasty, then you can remove the disc material, the compressed nerve. You can see the dura sac free. Here is the patient presented before. As you can see, we can do the conventional discectomy, sequestrectomy after doing annuloplasty. You can easily remove the sequester. Here there is a case with cranially migrated 4.5. There's a 3 herniated sequester with discectomy and annuloplasty. So we always try after making the compression, make sinovertebral nerve denervation, because we don't want for the patient postoperative discogenic back pain. So after annuloplasty, we are removing the free fragment, and you can see the compressed neural elements. It was an interesting case, only 15 years old lady with a discectomy and annuloplasty at the level 3-4 on the right side. You can see before and after the surgery, and the vascular dropped down from 9 to 1, so with very, let's say, well acceptable ache only from severe pain. This is the patient we perform discectomy and annuloplasty at the level 3-4 on the left side. As you can see here, preoperatively, and this is 6 months after the surgery. And again, the vascular was 0 6 months after. The patient was very happy and completely recovered after this minimally invasive surgery. Another patient with back pain, right-sided leg pain, VAS almost 10. After 1 month, only 1 with the discectomy and annuloplasty, 4-5 on the right side, and is 1 month after the surgery. Another patient, we perform discectomy, annuloplasty. The patient had before back pain, right-sided leg pain, and did neuroplasty before. So the free fragment was removed. You can see before and after the surgery, and the patient nicely improved. It was around 3 months after the surgery, the improvement time. You can see step by step how the herniated disc is removed and annuloplasty performed. For those kind of patients, if you can see these modic changes, sometimes we do additionally this basovertebral nerve, also the nervation, this intra-sept procedure, if the patient is still having some back pain. Another case, back pain with acute herniated disc at the level 1 and 2, we did annuloplasty and discectomy, and the vascular was 2.5, 4 months after the surgery. He's also happy, nicely improved. Another, it was a discal cyst at the level 4-5. So we did annuloplasty and annulotomy, and the vascular from 8 dropped down to 3. It was 1 month after the surgery. A patient with back pain, chronic left-sided leg pain. It was pseudocyst before the endoscopy. Some, unfortunately, intracanal scar tissue formation. So we did release the scar tissue and annuloplasty. The patient decreased VAS score from 8 to 2, 5 months after the surgery. Another one, chronic low back pain. It was 55 years old lady, similar situation, operated before we did annuloplasty, and we also released the scar tissue at the level 4-5 on the right side. Here you can see the patient with annuloplasty at the level 4-5 on the right side, and this scar tissue release, and we use this YAG laser for this patient. As you can see, the indication for annuloplasty, the discectomy and annuloplasty depends on the patient pathology. It's very wide. You can perform only annuloplasty. You can also perform the discectomy annuloplasty. So it's very similar to transforaminal endoscopy rigid monoportal, but additionally performing this sinovertebral nerve denervation, we can also decrease postoperative discogenic back pain. So the indication is symptomatic annual flare, herniated nucleus with predominant back pain, failed back surgery syndrome, disc ulcers, biopsy, and the patient has to be adult. Contraindication, if we have large herniated disc with radiculopathy, better the conventional monoportal or interlaminar if this is the level 5S1 is indicated. Hard disk calcified, we cannot operate. Severe stenosis, also segmental instability, disc degenerative disease grade 5. Still, we have to have some hydrated nucleus and minimum osteophytes. Modic changes we can combine with intracept, intravertebral, basovertebral nerve denervation. At the level 5S1, rather interlaminar approach is recommended. Infection, tumor biopsy is contraindicated. Complication like for the conventional endoscopy, bleeding, viral neural injury, annual damage, headache, unfortunately can happen. This technique is very familiar for all of you who perform transforaminal procedures, starting from the discography and monoportal endoscopy. It's very safe. The access is very easy. There's a very good orientation, and the scope is semi-rigid. This is why we can very nicely visualize anterior epidural space. There is a very clear visualization, and we are not using steroids performing this procedure. Unfortunately, there is some limitation, high iliac crest. This is why interlaminar approach is much better. And the instruments most probably seems to be a little bit updated currently, because in the beginning we had some injury of the annulus. We are using right now this elastic working channel, so the injury of the annulus iatrogenic is very, very minimum. I was presenting the transforaminal here. You can see the case at the level 5S1. It was interlaminar epiduroscopy, discectomy, and neuroplasty. So we can also easily utilize at the level of 5S1, where we have this wide interlaminar window, and we can perform the same decompression like for the interlaminar monoportal procedure. This is the patient with the chronic recurrent aggravating back pain at the level of 5S1. Interlaminar approach was performed. As you can see, this is before and after the surgery. It was on the right side. This is how it was done with this extruded inferior migrated disc, 5S1 on the right side. This is the pre-op, and the day after the surgery, the patient nicely improved. He was basically pain-free. Another one with the neuroforaminal stenosis, we did laser foraminotomy at the level 4-5 on the right side for this case, without using the drills, only this laser presented before. Here there is a male patient with 5S1 bilaterally herniated disc. Also interlaminar approach was performed for this patient. So in summary, this transforaminal epiduroscopy laser annuloplasty is a new extradiscal annuloplasty. We are not performing an intradiscal like for IDET, for instance. It's very minimally invasive, safe procedure in local anesthesia and very superficial IV sedation. If you have additionally the MRI evidence of the end plate change, you can also perform additionally this basovertebral nerve denervation, so you can combine discogenic and vertebrogenic back pain. performing the stimulated prodding, we know how effective is it during the surgery. We can also remove extruded migrated disc. We can perform contained herniated disc discectomy. We have contained herniation, same like for the monoportal endoscopy. And the annual defect, because of the construction of the scope, is very easy to access this anterior epidural space. So this sinovertebral nerve denervations are effective. I would like to thank you, Dr. Lee, who was my teacher in South Korea, and thank you so much for your attention. Appreciate it.
Ziggy, you have left us breathless. I think Dr. Marisa must have really enjoyed your talk because she had spoken on sacral epiduroscopy. Dr. Anand Kavi also does sacral epiduroscopy, and today you have introduced us to the world of transforaminal epiduroscopy. So thank you once again.
Thank you so much. Thank you. I appreciate it. Thank you. Thank you for inviting me and for giving me a chance to be together with this prominent doctors all over the world. Thank you very much.
Our privilege. Can you please exit your
yes, screen?
Dear friends, we have come to the end of our second World Congress. 55 speakers, 2 days, non-stop, hammering of endoscopic spine surgeries with the best of the best in the world. It has been a pleasure and it has been an honor. And I really don't have any words to express my gratitude to all of you panelists who have given your precious and vital time to us. We are growing and we hope to grow with all of you in the future again. Before I conclude, I want to thank our event managers, HealthQ First, and their IT team. I want to thank Endovision. I want to thank Carl Stores. I want to thank Endospine Max. I want to thank Max Moore and even Bonds. All of them have helped put up this platform. All of them have helped coordinate with faculties and bring this Congress to its flavor. So I'm really grateful to everyone. I'm very grateful to Dr. Sameh, who has been like an elder brother and who has been a guide and who has been the energy behind this conference. I have a special thank you to our chairman of ESFI, Dr. Anand Kavi. It has been an honor to have you. And once again, to all the panelists, a big thank you. Dr. Sameh, if you'd like to say a few words, please.
Thank you. I'd like to share one photo before I start my talk.
Dr. Sameh, your system is hung, or Dr. Sameh, can you hear us? Dr. Anand Kavi, if you would like to say a few words.
Yes, I would like to sincerely thank you, Malcolm, for putting up this great show. And I would also like to thank all the participants and all the esteemed speakers, panelists, for giving their time and having wonderful presentations. And I think this format is one of the best format for spreading knowledge. There was no exhibitions, there was no dinner breaks, lunch breaks. It was just academics throughout 2 days. So it was a great academic feast, and I'm sure we will continue this in the coming years and make it better and better. So thank you once again to all of you.